Before attending to any fetal delivery, make sure to have a surgical cap, a surgical mask, and a pair of clean scrubs. Next, prepare the complete delivery materials on a sterile tray. We have the antiseptics, surgical gloves, operating sponges, towels, oxytocin, syringes, scissors, clamps, umbilical cord clamp, and a suturing set. Next, we perform the correct hand washing and scrubbing. We start by pre-washing our hands when our hands are soiled. When it is not soiled, start by cleaning the nails using a nail pick under running water. Next, grab a sterile brush or sponge. Using the abrasive side of the sponge, start by brushing the nails with 10 strokes. Afterwards, flip the brush or sponge to the non-abrasive side and scrub the hands 10 times on the front, the back, the sides, and between the digits. Next, we scrub the forearms on all sides until we reach the elbow area. Next, rinse the soap off in running water in one direction. Do the same for the other arm. Finish by lifting the hands above the elbow and maintaining it in a 90-degree angle. Next, perform proper surgical gowning. Next, using surgical gloves, perform proper surgical gloving. After positioning the patient in a dorsal lithotomy position in the delivery bed, place sterile drapes in a way that only the immediate area around the vulva is exposed. Next, perform vulvar and perineal cleansing. We then instruct the mother to push only when there are uterine contractions, and then we wait for crowning to occur. When the fetal head distends the vulva and the perineum enough to open the vaginal introitus to a 5 cm diameter, use one gloved hand with a sterile towel to support the perineum, while use the other hand to guide the fetal head through the introitus to avoid expulsive delivery. Once the fetal head is delivered, check for knuckle cord by slipping a finger across the fetal neck. If the coil is loose, slip the loop over the head. If it is tight, clamps may be applied and the cord is cut in between. After the delivery of the fetal head, we watch for external rotation until the fetal head assumes a transverse position. Usually, the shoulders are born spontaneously following external rotation. However, there are cases when shoulder delivery is delayed. Here, we grasp the head with 2 hands and apply a gentle downward traction until the anterior shoulder appears under the pubic arch. After that, apply upward movement to deliver the posterior shoulder. The rest of the body almost always follows the shoulder without difficulty. Once the delivery of the entire fetal body is complete, Place the baby onto the maternal abdomen to facilitate early skin-to-skin contact. We then proceed to cord clamping. First, we need to delay cord clamping for at least 30 to 60 seconds after birth or when cord pulsations stop. Then we place two clamps at 6 centimeters and 8 centimeters from fetal abdomen and cut the umbilical cord in between these clamps. We now proceed to the third stage of labor, which is the delivery of the placenta. First, we need to prepare a basin near the perineum. While holding the clamp on the other hand, palpate the uterus using the other hand to check whether the uterus is atonic or filled with blood. We then look out for signs of placental separation, which include the sudden gush of blood into the vagina, the uterus becoming globular and firmer, the uterus rising to the abdomen, and the lengthening of the umbilical cord. Once these are seen, apply gentle and controlled cord traction, not pulling, and express the placenta through the vagina. Next, we need to prepare parenteral oxytocin. Administer IV oxytocin at a rate of 10 to 20 milliliters per minute. If there is no IV access, we can administer 10 units of oxytocin intramuscularly. Next is to check the placenta. Normally, the membranes are intact and the cord insertion is located centrally. Examine the other side of the placenta to check for gaps as well as missing cotyledons. The cord should contain 3 vessels, 2 arteries, and 1 vein. If there are lacerations, they must be repaired. We can start by administering anesthetics locally. For perineal and episiotomy repairs, we can do a continuous suturing method, which is faster than placing interrupted sutures and yields less pain. After repair of lacerations, we then check the uterus for contractions before cleaning the perineum with antiseptics. After completing the task, clean up, remove the gloves and gown, and place them on the designated bins. Perform thorough hand washing afterwards.